Chairperson, ladies and gentlemen, at the outset, I would like to thank the Indian Orthopedic Association for giving me this honor of giving a eponymous lecture in the name of a legend of orthopedics in this country, no other person than Professor B.Mukhopadhyay. Professor B.Mukhopadhyay, born on 1st January 1916 in a very modest and poor family. Dr. Mukhopadhyay was a brilliant student who never stood second in his life. On a scholarship, he went to a medical college and got distinction in all the subjects and a Wheeler's Medal. He joined Indian Army, went and did his fellowship and MCH from England, came back and joined the Patna Medical College and became the first professor of orthopedics in whole of the Bihar. He established one of the busiest practice and got patients from Nepal and other far-off places like Burma. Probably he was the busiest orthopedic surgeon of his time. In spite of that, he always had time for his family. His three sons, all brilliant in their own way. One joined the Indian Foreign Service and is now an ambassador. One is a leading lawyer in the Supreme Court at Delhi. And of course, you all know John Mukhopadhyay, a leading orthopedic surgeon of this thing. He always cared for his students and saw to him that their career is taken care of. He was always looking for the talent in the Indian Orthopedic Association. And his greatest contribution to this country was that he established orthopedics as a separate specialty against much resistance from the general surgeons. He, along with Dr. B.N. Sinha, Dr. Karam Singh Grewal, Dr. A.K. Gupta, and 10 other orthopedic surgeons were responsible for founding this Indian Orthopedic Association. He was the first secretary. He was the first editor. He was the founder chairman of the Orthopedic Foundation of India. He was the chairman of ELIMCO. He was the president of Indian Orthopedic Association and Association of Surgeons of India. He became the director of health services of Bihar. He was the founder fellow of the National Academy of Medical Sciences, a very high honor which is given to purely on your academic achievement. He was a Dr. B.C. Rai awardee, and he got a very high civil award, the Padma Bhushan from the President of India, and at the age of 80, he authored a book, a age when most of us are sitting in our garden, watching the roses, reading newspaper, and enjoying our coffee. He was the first Indian to deliver the Hunterian lecture on 13th October 1955 on an osteoarticular tuberculosis, results of the treatment of 941 cases. At that time, when there was no way to maintain the records, he used to maintain the record all by his own hand. I have seen it myself at his house. And this, his Hunterian lecture, made a sea change in the thinking of the treatment of osteoarticular tuberculosis. He was a very accomplished surgeon. Those who have seen him operate will bear with me. He was a very dedicated and committed teacher, a crusader against the falling standards in the medical education, ethics, and the practice. His favorite subjects were osteoarticular tuberculosis, bone and joint infection, and a neglected trauma, and of course, a clubfoot. He once told me, look, Devin, I might have treated about 5,000 cases by myself, and that must have been the world record. And this is because his subject was very favorite, and one of my favorite subjects has been the clubfoot, and therefore I thought I'll share my thoughts of my 45 years experience, and the title of my talk is Yesterday, Today, and Tomorrow, and my journey of 45 years. Let us look into a very basic things. The incidence of a clubfoot in the Western world is much less than in the developing world. We have a much higher incidence. It has been now proved and maybe it is a racial, chromosomal, or genetic, or all other factors are we taking into this thing. We always share the agony and ecstasy of treating this clubfoot. Who will deny that when a mother gives a childbirth to a child and who has got a clubfoot, and there you could always see the tears in her eyes. But within a month or two, when you have treated the child and his feet are plantigrade, you can see the happiness on this child. And these children remain with you all your life, and they share their happiness and their secrets of their life. The clubfoot has been attracted many authors, many writers, and this book of human bondage, which you all must have read, and the hero in this book, Phillips, who has been humiliated because he was a clubfoot, and his dialogue with his mother brings tears into your eyes. In the Madame Bovary, the person who has a clubfoot undergoes an amputation. It has attracted many painters, and you can see these famous paintings in the Louvre at Paris. Kamlesh Tiwari, whom I had treated 27 years back, came recently to me, and I saw he was so happy and so delightful that it gives us a happiness that after 27 years he is so walking well, although you can see some of the hindfoot varices there. The etiology is now, of course, is very much a chromosomal factors play an important role. The mother brought her child, and mother told me, "Doctor, you treated me, and my feet are not good. Don't treat me, my child, like this thing." And my answer was, "I have now a better method to treat your child, and I assure you, you will not get that bad result as you got it in your things." But we have now the better tool of investigation. We have got MRI, we have got a Doppler, which tells us there is much more to the clubfoot other than the multifactorial etiology. The anatomical facts are much more now clear as on today. We know that there is abundance of collagen in the ligaments, which are responsible and which are stretchable, which can reform on every 5th day. But tendo-Achilles has a different thing to speak, and you have to do a tenotomy for this thing. The kinematics is much better clear. We now understand that there is no single axis of motion which exists, and the movements of each tarsal bone involves a simultaneous shift in the adjacent bone like a chain. Like you can see this gear system, if you move one tarsal bone, all other tarsal bone also move on their axis. The growth and development has been talked about, and it is being considered as a dynamic deformity because a damaged growth nucleus and a tendon lengthening retards the growth of the foot, whereas a repeated stretching and relaxation stimulates the growth of a foot. A lot of things had been talked earlier in 1988 and 1991, and we talked about that there is no standard method of classification. Scenario has changed totally as on today. There are many prevalent classifications, out of which the Miglo, Pirani, and international clubfoot study groups has been well universally accepted, and this is a photograph recently when I met Pirani in Prague. A lot of things has been talked about the analytical radiography. When George Salmon published his article in 1977, we all started doing analytical radiography, and we thought it was very important to do this thing. But it has now been accepted that a non-accurate replicability or inter and intra-observer variation and pitfalls are there. Therefore, this is not a standard method of evaluating your fit. However, ultrasonography, this parameter shows a much significant correlation, and sonography is certainly superior to the radiology. There is these days talk about the pedobarography. The pedobarography is a technique where you measure the pressures under the feet, and thereby you can evaluate whether your foot has been clinically corrected or this thing. But it is, that finding has been questioned, and therefore it is not a very popular method of monitoring. From 1968 to 1988 that I have been doing the clubfoot, the things were very different. From 1988 I got more interested and established the clubfoot clinic at Riva Medical College. We started going to different camps and picked up the patients of Clubfoot to our clinic and wrote it up our experience in the World Health Forum. And in 1992, when I came to Indore, I started and dedicated a clinic, which I called it as Dr. B.Mukhopadhyay Clubfoot Clinic, which is still running, where we have 573 cases running. The treatment of a clubfoot, in my opinion, has always been a very challenging. And the standard method that I had been practicing was a Kite method of manipulation. We looked into the original paper of the Hazaron Kite, which he wrote in 1930. We also looked into the original article by the Ignacio Poncetti, which he wrote in 1950, both in America. And we found that there are similarities on 17 points and dissimilarities on 12 points. And since the Kite method failed to understand the proper functional anatomy in the normal foot and the clubfoot, and therefore this method failed. According to Brockman, only you could correct such patient by this method in 30% of the cases. However, in 2001 we reported that it is not so. If you are persistent with these patients and do a correct manipulation, you can get a very good result. And we wrote it up in the Indian Journal of Orthopedics that really are the resistant clubfoot really resistant or not. But however, the revolution has come by the work of Dr. Ignacio Poncetti. We all know about it. But no method has free of any problem. Many pitfalls, you all know that, during manipulation, during casting, during tenotomy, and during braces, which has a direct impact on the result of this thing, out of which the casting and the bracing are two very important things. But very important thing is, which has come up now recently, that it works in the older children also. Marconde, who was the second to Dr. Poncetti in Iowa, USA, has said that you can do it up to 2 years. They have shown the cases which is even up to 9 years. Julian, who has shown that you can do these cases up to 11 years and 12 years. And Shah Alam from the All India Medical Institute has shown he has done cases up to the 7 years. This girl, Alina, came very recently to us, who had never been treated till 6 years of age. We said, we'll try this method. And you can see that at 6th placer, her feet has become fairly corrected. So this method works. We have been doing a lot of surgery in this clubfoot. Posteromedial release, tendo-Achilles lengthening, partial subtalar release, complete subtalar release, Cincinnati operation, and whatnot. Maybe we might have spoiled more than what we have treated. And all these surgeries, most of the results that you look into the literature show the results are not very satisfactory, and hardly about 50% cases you can get a good result. Every foot we learned has its own personality. You have to take a decision on the table. You have to have a a la carte approach, and that's what they say. Does the surgery make the foot stiff and painful? Lots of people have started talking this thing. I think it is an over-exaggeration of the statement, and I always have questioned this thing because, in my experience, if you have a foot which has got an indication for surgery and you have done the surgery well, I am sure the results are fairly rewarding. Here is a patient who has got 11 years follow-up, you can feet, were treated by surgery, fairly good-looking feet. This other patient, 14 years follow-up, you can see the feet are fairly good. Patient is happy, we are happy. Here's other patient, 16 years follow-up. You can see the feet who have been very well corrected by surgery. And this is Abhijit, 24 years follow-up. You can see that patient has got a hindfoot varus and forefoot adduction, but he is managing very well. So these are this thing. However, with the time, the incidence of surgery has drastically declined, and this is in the experience of everybody. We started with a conservative treatment and came to a radical release where we used to do a complete subtalar release from both medial, posterior, and the lateral side. And now again we are purely on the conservative treatment. That should make us very happy that this is one place where from an operative we have turned over to conservative. Otherwise in orthopedics, conservative word has totally almost disappeared. After treatment, still few people get recurrence. What do I do about it? And this recurrence is mostly between 3 and 4 years of age because of the abundance of the collagen. And the treatment, in my opinion, is that you must do a remanipulation and you can get an excellent correction. And if need be, you can do a tibialis anterior transfer. And this is a child, Raghav, whose mother is a physiotherapist. After a beautiful correction, she refused to give an abduction brace. She said, I am a physiotherapist and I can correct and keep the child stretching and my child will be all right. The child got a recurrence. We put her back into the plaster and the child came only on 29th December, 4 days back, and you can see the feet has been beautifully corrected. There are a group of patients where the treatment is always an enigma. Thanks to Dr. B.B. Joshi and Professor Eliezer Rao, who talked about the tissue growth by the distraction. And we also made some modification into the JESS method where we loaded them with different types of spring to create a dynamic force and treated this patient. A 9-month-old patient of arthrogryposis, you can see that what a beautiful correction has been done by the JESS method. Both the knee and the ankle deformity has been corrected. Arvind, at 7 years follow-up, who had undergone surgery, very bad recurrence, has been treated by the JESS, and you can see the results. The patient has got even the overcorrection because also the patient has undergone a complete subtalar release operation. This is another patient, Balwant, totally a neglected clubfoot, again treated by the JESS method, and you can see the 10 years follow-up that you can always get a correction. Pallavi, who had undergone 2-3 surgery, had a bad recurrence. This is at 10 years, and this is at 21 years. She came recently. You can see with the nail polish that she has been married, has got a child, and lives now in Baroda. We wrote it up in the Journal of Foot and Surgery about the spring distractors treatment in a clubfoot. In my opinion, the treatment of a neglected clubfoot is entirely cosmetic because if you go into the literature and go into the internet and see, the many people with a clubfoot had been playing football, baseball, every game they can play and they can do this thing. What is important is that this deformity is causing them a lot of humility and they cannot get into the government services. And this is one such example. You can see how the feet can be beautifully corrected. So we tried to work it out, a correlation between the clinical and radiological corrections, and we picked up 43 feet in 32 patients. And these are the patients, 6 years follow-up, 4.5 years follow-up, that they have got some deformity which is persisting. Sher Bano, who had you can see the talocalcaneal angle, the parallelism is persisting. There's a severe deformity in the foot. And when we worked it out, their functional scoring, we found that a lot of patients, majority of them who had a deformity, but still their functional score was extremely very good. This girl had a 4-foot erection and mild hindfoot varus. Still she was very happy, no problem, running around. The parents were happy, the child was happy. We also found it out. When you have a foot where you have corrected it clinically, but still radiological correction was not there, and this amounts to 25%, and we labeled it that these are the 25% which needs a very close observation, and what we call them as a foot at risk. The maintenance device is very, very important. We use the Dennis Brown splint, we use an ankle foot orthosis, we use the Orfit brace, we use the Easy Foot brace, polypropylene bases, but never have been happy till we have now found a Steenbeck by what the Ponseti has given. We also found it out that the Robert Jones shoes that we were supposed to be giving these patients were not very effective. We made some modification and called them an indoor shoe. You can see a cut from the posterior side, which shows whether the heel is on the sole or not. We had an ankle strap to keep the heel touching the sole. We also had a 4-foot strap to keep the foot into abduction 4-foot. And the role of this shoe, we wrote it up in Indian Journal of Orthopedics, and we did that how it is important this thing. Total, from 1988 till this, we have 1,265 feet treated. At Arihant Hospital, where now I work, we have 173 patients registered and 249 feet. And in majority of these cases, you will see that 193 patients has been treated by us by a Ponseti technique, and where the majority of them had a severe deformity, and 73 had mild to moderate deformity. And this Bani scoring after treatment that improved drastically. And even when we tried to put the 50 feet who had a long follow-up onto the ICFG score, we found the majority of the patients had an excellent result. This is the one patient, Ishan, 4.5 years after treated by the Clubfoot. You can see how beautifully feet has been corrected. Another patient, 6 years follow-up, you can see how the feet has been beautifully corrected by Ponseti. Another patient, 7.5 years follow-up, you can see he has got some deformity of the forefoot adduction, which has not been corrected, and there is sometimes the overcorrection you can see on the right side, and there is at hind feet level. This is another patient, Kuldeep, 8 years, and you can see that there may be some deformities persisting, but these children have been extremely happy. So when we re-look into our treatment, we found that those treated by the conservative methods, their feet are strong, they are supple, and they are pain-free, and patients are happy. However, those treated by surgery, they are not too bad. There is some stiffness, there is some pain, but there is a scar, and this is what the main outcome of this patient is. We also, when I was working in the medical college in Indore, I obtained a computerized gait analysis machine, and we gave that let us study the gait in these patterns, and we published it in the Indian Journal of Orthopedics, and our conclusion was that howsoever beautiful correction you make, the gait parameters do not reach to a normal level. In 2001, I gave my kidney memorial oration on these things. And as on today, what is the difference between yesterday and today? The etiology was not clear. Today we are absolutely clear. The pathoanatomy was not properly understood. Today it is far better understood. Kinematics, there was no concept. Today we have a full concept of the kinematics. The Kite manipulation, and today we have a Ponseti method and we have a French method. There were a lot of surgery and extensive surgery we were doing it. Now we do surgery very minimal, and just and the Lizerol is the treatment of the choice. Very high recurrence rate yesterday, and today we find very few patients undergo a recurrence. And there is no good brace was available, but there is a very good brace available now. So, what is the future and what is the tomorrow that I am looking into this thing? So for that, I have a dream. And my dream is that we have now eradicated polio from this country, thanks to the government, thanks to the NGOs. Now what about these children who are born with this clubfoot, who cannot become a protective to our country, who are being humiliated in the society, that we all owe something to them, and you do not want them to grow up and walk like this, the child is walking about it. A country where there is a gender bias, the girls are not brought to the clinic for the treatment, and therefore, I think you have something. A country where 70% population is living still in the rural area, but there is a revolution in the communication. Everyone has gotten a mobile phone, and mobile phone has gotten a camera into this thing. So my concern is that every year you are having 40,000 new patients of clubfoot being born in this country, out of which the 28,000 are in this rural area. So can't we have some type of a tele-rehabilitation program? And because we all know that if an early intervention is done from day one, the clubfoot can be cured within a month to 2 months' time. For that, what I have some national vision based on my experience of last 45 years, and for which the Indian Orthopedic Association can play a very important role. The president and secretaries are sitting here, and president-elect is also sitting there. What Indian Orthopedic Association can do? Form a clubfoot study group. Involve the government, the NGOs, and the public. And the clubfoot awareness campaign for the local DAIs, Anganwadi workers, and support a tele-rehabilitation program, and full use of IT technology. This has come up in a big way, and tie up with an organization like Cure International. I have just to show you that if you can have a child born, and everybody can take a photograph of that from different angles, send it to a center on the internet, those photographs, and prepare a prototype in a computer, prepare a silicon model, and try to prepare a custom-made, computer-generated dynamic brace which works on the principle of an upon SETI. Can this concept work? I'll show you that it works. We, with the help of the engineering department at Indore, we've made this device. We are planning, and this is a concept which I'm giving and which, in my opinion, seems to work. This, and with this, you will have a minimal visit to the hospital, and you will have minimal use of a plaster. Maybe a day may come when the plaster will go out in the treatment of a clubfoot. There are many community-based rehabilitation programs on all over the world. We can have these type of program with the help of Indian Orthopedic Association. Lots of my students from 1989 till 2013, whom I motivated to do their thesis in the Clubfoot, or many of them are sitting here. I am very indebted to, grateful to them who have always been with me in my journey. And to all these my children and their parents, who has always been very patient with my all the time when we have been treating these patients. But this challenge of clubfoot is not over. It continues. The patient with the clubfoot come in different way, different forms, and this always throw a challenge to you. Okay, doctor, now you treat me and let me see what your 45-year experience can stand. Now, here is a man, Dr. B.Mukhopadhyay. On the other side, you see another legendary of the orthopedics of the world, Sir Robert Jones. Robert Jones did establish the orthopedic specialty in Great Britain against much resistance of the general surgeons, and he was the man who was responsible for forming a British Orthopedic Association. Dr. B.Mukhopadhyay, for him, Robert Jones was his role model. Same role Dr. B.Mukhopadhyay played when he came to India. Both loved treating clubfoot. Both wrote extensively on clubfoot, and no wonder Dr. B.Mukhopadhyay is called as a Robert Jones of India. At this stage, I am reminded of a very famous couplet of Allama Iqbal, which says, Hazaron Sal Nargis apni benoori pe rotee hai, badi mushkil se hota hai, chaman mein didawar paida. I think this is what he wrote when he has a man like this in his mind, because person like Dr. B.Mukhopadhyay are born once in lifetime. With these words, I dedicate this lecture to Professor Dr. B.Mukhopadhyay, a visionary of this country. Thank you, ladies and gentlemen, for your attention.
Though it is not a customary to speak something after this type of lectures, our heartiest regards and congratulations to Dr. Taneja, who is a close associate of Dr. Mukhopadhyay. So am I. I was very close associate to Dr. Mukhopadhyay. So it is wonderful for the new generation of orthopedic surgeons. They should know two persons in India.